And our last speaker for this morning session is Bronwyn Thomas, an anaesthetist. There's no operation can start without an anaesthetic, and this sort of brings us into the clinical part of the symposium. Thank you very much.
Thank you. Hello, everybody. I've tried to make this as interesting as possible because I know how hard it is for a surgeon to listen to an anaesthetist. So why am I doing this talk? That's a very good question. Dr. Wasocki couldn't really find anyone else. I think it was the third person he asked, and he caught me at the end of the list. So thanks very much. Other reasons, perhaps because we work at a peripheral hospital which has got a high proportion of high BMI patients. It's actually more the norm to have heavier patients. It's quite rare to have an ASA1 patient who's 60 or 70 kilos. They're more likely to be 90 kilos. And I've actually boned up on all the details I should know about my anaesthetic drugs after doing this talk too. So what doses I should be using in all these obese patients. And Dr. Wasocki also thought of the title, and I thought that was suitably whingy, and it is something I would say. So true. So why I don't want to, it's Monday and I just don't feel like it. I have my cranky pants on because you've given me a terrible patient. Because they look very dodgy. Ischemic heart disease, diabetes, smoker, asthmatic, current ERT, that's quite a normal patient on our list. But also, the thing that adds a lot of stress to the list is that they're overweight. So this one doesn't scare me quite so much. I think he's all rock, but if it's muscle mass, I don't mind. If the high BMIs, that's the reason they have one, is because they're full of muscle. And why is it such a big deal for us? Why should you care? So you should care because it does take us more time, and I know there's always the pressure on us to try and hurry it up because then you get more surgical time. But unfortunately, with an obese patient, it's going to take as long as it takes. So it's in your interest to warn us if you've got an obese patient, because then we can prepare and perhaps limit the amount of anaesthetic time before you can start your surgery. So apparently our cutoff for elective surgery, which I found out the other day, is 60. And emergency surgery, well, it doesn't matter how big you are. And essentially, I pretty much think they're skinny if they're less than 100 kilos, which is pretty sad. So I think that's common for most of the anaesthetists in our department, that we think, 100 kilos is the norm. And it's very common to have BMI 30 to 40, and it's not rare to have 50 to 60, at least every day. You at least get a BMI 50, and at least every week a BMI 60. And it's not just Logan, it's every hospital in Brisbane. I've got friends at other peripheral hospitals and tertiary hospitals. They just had a 180 kilogram patient the other day. It's not rare, unfortunately. And of course, you also get them in private land. So BMI. So it's your weight in kilograms over height meters squared. So a good question that someone suggested in my department we should ask the patients, or as a way of broaching the subject that they might be overweight, was perhaps point out how tall they should be for their BMI to be normal. So BMI doesn't actually take into account if it's due to muscle or fat, and that's quite important. As I was pointing out with my picture before, it's not such an anaesthetic big deal if it's due to muscle. And it's much more important where the fat is. So he doesn't scare me as much, and his BMI is high. I was trying to guess what he might weigh and how tall he is, as long as he's not on steroids, of course, because then he'll have his steroid-induced cardiomyopathy. So he doesn't scare me as much as someone who's 142 centimetres tall with the same weight. So they're always changing definitions. So morbid obesity used to be BMI over 40 or greater than 35 with associated things like hypertension or diabetes. And then the World Health Organization, the latest classification that I found when I was reading up on this, they've kind of changed a bit of the classification. So obese class 1, obese class 2, and obese class 3 has replaced morbid obesity. But pretty much we're just talking BMI 50, 60. So as I was saying, I think it's much more important, and I'm sure I'm not alone, that it's the shape of the patient. So if you get right down to it, Mr. Happy is actually obese, and he's an apple. So Android, they're generally more likely to cause airway anaesthetic problems because more central fat, but it's also up around the neck and the airway. There's a lot of definitions to figure out if they're an apple or a pear, but it's pretty obvious when you look at them. There's some definitions there. And they're probably more likely to have the metabolic syndrome as well, and males more than females. And then you've got the other end of the spectrum, which is a pear. So they can be a bit more easier for the general anaesthetic because the fat isn't around the airway or the lungs, and they can be more of a problem when you're trying to do a needle in the back though, because obviously all the fat is distributed around the hips, and quite difficult for IV access because it's on their limbs as well. So I thought there's always someone who likes Star Wars, so I just thought I'd put that in. So Jabba the Hutt, he's kind of like an apple that swallowed a pear, or the other way around. The sad thing is I actually had a patient who resembled this body habitus, and I think the bigger you get, the more you resemble this kind of enormous quantity of obesity. He didn't have a tail, but he had very short legs. And he was a lovely, lovely gentleman. He was in his 60s, and it wasn't the main issue that he was obese, it was more his comorbidity. So he was, he was probably 70, so elderly. He also had post-polio syndrome, so he had the very short limbs from the polio. Then there's all sorts of anaesthetic implications from the post-polio syndrome, so in terms of what drugs we can use. Then he had the obesity. It was all around his face and his neck. He had all his teeth, so he was a difficult airway, grade-3 airway, difficult to ventilate, and also had aspiration, like he also had a high aspiration risk, so he was a bit of a nightmare for me. So, yeah, they can be a difficult anaesthetic. So, yes. So it's a kind of an independent predictor of a difficult airway for us if they've got a big neck circumference. So I think Jabba the Hutt would probably be tricky for an anaesthetic because he's got no chin, but he's got a big tongue as well, so it's quite hard to get around the corner when you try and put a tube down. He doesn't really chew anything, if you watch Star Wars, and he's probably going to be difficult ventilation because I don't know what face mask would fit on his head. But it probably wouldn't be very hard to put the tube down because he could open his mouth up quite wide, and he's probably got rotten teeth as well. So comparing BMIs between characters, because I thought this was probably a little bit more politically correct than actually putting real patients up there. So Superman, I thought he was probably at least 190 centimetres tall and 100 kilograms, so BMI about 28. He's probably even heavier because muscle weighs more than fat, so he's probably more like 120 kilos. So he is actually obese, according to BMI. But I wouldn't consider Superman obese. Whereas Yoda, I was trying to guess, he's about the size of a 4-year-old. I reckon he must be about 25 kilos, 90 centimetres, so he's obese as well. Essentially, if you're about a kilogram per centimetre of height, you are morbidly obese. So these are just the ones I've had this year that stick out in my head, just recently. But you know, there are other people in my department who've had heavier patients. So emergency perianal abscess, he was 180 centimetres, 176 kilos, BMI 54. And we managed to get away with just sedation for him and avoid a general anaesthetic. Thankfully, we had a very nice surgeon who was happy to kind of work around his risk. We did try and put a needle in his back. I was trying all the extra long needles, and I couldn't do a spinal on him after multiple attempts. And it's only for a small operation, so we got away with just some sedation and local anaesthetic from the surgeon. The other one that I had was for grommets and removing of nasal polyps. So blood in the airway at the end of the operation. So nasal polyps is kind of like a bit of a nasty one for that. So anyone who has blood in the airway at the end of the operation is a risky kind of wake-up for us. So I wasn't looking forward to that case, but thankfully we were able to cancel the nasal polyp operation with the ENT surgeons and just do the grommets under local anaesthetic. And I did talk to the lady about perhaps losing 60 kilos if she wanted to get her nasal polyps done. Because the problem was she thought the reason that she was having problems breathing was her nasal polyps, not her obesity. So there is a bit of denial amongst patients about what the issues are. So issues pre-op. Obese patients are difficult for the IV cannulation. You can't see or feel them, so you might need ultrasound to get your drips in. So of course that's going to take more time. And more prone to tissuing because of the depth of where their veins are, so your drips are more likely to tissue. So you may only get a small drip in and then it's going to tissue on you because of the depth of the fat. Positioning is difficult. You know, the logistics of it, you know, the warties that you need, extra staff so people don't hurt their back, hover mats to try and move patients between beds. So that's a particular movie that sticks out in my head that kind of illustrates a lot of the things I'm trying to say. So positioning is very difficult with obese patients. I didn't actually find much data on pressure areas being more common if you're obese, but certainly it's harder to position patients on the bed because they're kind of spilling over the bed. So certainly for laparoscopic surgery, where surgeons want arms by side, it's quite difficult for the arms not to fall off the edge of the bed and for arms to touch metal, so you might need to put arm boards at the side to keep the patient in position, which makes it harder for the surgeon, of course. So there's all these kind of considerations we have when we're positioning the patient, that if they're going to be there for like 4 or 5 hours, that we don't end up with pressure areas afterwards. So I'm not sure if they're more likely to have a pressure area, but certainly they're harder to position, so maybe that predisposes them to getting them. Certainly venous stasis is more likely if they're obese, so then we have to make sure we always put appropriate prophylaxis on as well, like stockings and compression. So we have a hover mat to move people across from the bed to the table at our place, and the cutoff is 120 kilograms. It sounds like a vacuum cleaner when you use it, but it's very effective. And again, we have to be very careful because it's our responsibility for the positioning and also, you know, moving the bed up and down. So being careful your patient doesn't slide off the bed when the surgeon wants them upside down. Yep, as I said, bed capabilities and also positioning the patient. So if you're going to turn the patient upside down, prone, and they're obese, obviously that's a logistical nightmare for us and requires a lot of audits, a lot of staff to move them and to do it safely. And obviously they're more likely to need an endotracheal tube if you're going to go in a prone position. In terms of positioning for us, reverse Trendelenburg is wonderful because it's ramping the patient in a position that is good for their respiratory, the best respiratory position for them because they're head up, so it's easy to ventilate an obese patient rather than putting them head down when everything falls up, like the diaphragm falls up on the lungs. So that's obviously not what our best position would be. That's what we're about. Okay, so induction for obese patients. So induction is putting them off to sleep. So as I said, head up position, ramping, it's so important for obese patients that we do that. Induction can be rocky. It's harder to ventilate them, maybe more difficult to intubate them, and they desaturate quickly. They just don't have the oxygen reserve that someone who's not obese does. And they've also at increased risk of aspiration, which means they've got stuff in their stomach that can come up into their lungs when you put them off to sleep and you relax everything with your drugs. So when I say harder to ventilate, that's just putting the face mask on them. It's hard to sometimes get the face mask to fit their face. Using 2 hands to actually ventilate them, Goodell's, all sorts of things to try and actually open their airway when you put them off to sleep and ventilate them. And certainly an obese airway is more prone to collapse. So once you give anaesthetic drugs, whether you give a muscle relaxer or not, even just the propofol, everything just sort of falls backwards and it's much more harder to ventilate them. So if the airway falls backwards and you're not keeping your airway open and you're pushing pressure into what you thought was their lungs, you're actually going to be pushing it into their stomach again. So if they're at risk of aspiration, you can then make that a lot worse. And muscle relaxants may or may not help with the ventilation of an obese patient because the problem is sometimes just collapse of all this soft tissue. So in terms of desaturating quickly, when you put them off to sleep, they've got a higher basal metabolic rate when you correct it for their body surface area. So they've overall greater oxygen consumption and more CO2 production. And basically everything's a bit, basically increasing the oxygen consumption compared to someone who's not obese. They also can have small airway collapse at their normal breathing tidal volumes. So they're already a little bit hypoxemic compared to someone who's not obese. So you're kind of starting off behind the 8 ball with an obese patient. Functional residual capacity, that's something anaesthetists love to talk about, but essentially it's the volume in your lungs at normal tidal breathing when you're taking your breath out. And this is what we are trying to fill with lots of oxygen during that little 2-minute period where we're trying to just put the face mask on them to try and buy us a bit of time when we put them off to sleep so that they don't desaturate. But in an obese patient, you have less reserve, essentially. So you can spend as long as you want putting your oxygen mask on at the start of the operation before you put them off to sleep, but they're going to desaturate much more quickly than someone who's not obese because they've got higher oxygen consumption and they've got less reserve. They also have things, problems with compliance so it's a bit harder to get a change in volume for the pressure that you put in because they've got increased pulmonary blood volume. They also can have a restrictive lung defect because of the obesity around their chest wall, so it just makes it all a bit harder. So it's not just obesity that can cause a problem. So if you're a bit hairy, that'll also make our life difficult when we're trying to put a face mask on you. So if someone's got a really big beard and they're obese, then of course it makes it all a lot worse. So yeah, I think he would be a bit hard because he's got a lot of beard. So in terms of increasing risk of difficult intubation, it increases with obesity. And then when you add other things in that would make an airway difficult, then you've got a perfect storm. So it's not just obesity in isolation that causes us a problem, it's also if they have something else that makes them hard. So anything else that would make a person hard with, if they weren't obese, so small mouth opening, they can't put their head back, they've got all their upper teeth, that's always a problem for us, we prefer dentures, upper dentures, it's good. Always got to be very careful with people with beards because they're usually hiding a small jaw, and that's usually a problem for us because a small jaw is hard to put forward and there's no room to push the tongue. So basically when we're intubating someone, we're trying to push the tongue out of the way and put the jaw forward. So if we can't do that, our angle for putting the tube in is a lot harder. And obstructive sleep apnea can also be associated with difficult intubation. So people that are obese have a high incidence of obstructive sleep apnea, but you can have obstructive sleep apnea without obesity. And it usually means you've got something anatomically wrong with your airway. So that actually would make you a difficult intubation by itself. So if you've got both, it can make everything a lot harder. I think he would be hard because he's got no chin. And I think he might be. Like in terms of all these rules that we have, apparently he's supposed to be hard because he's got a big thick neck. What else? And the other thing is too, their big chest walls, they've got lots of obesity centrally. It's sort of like having a pregnant patient when we're putting our laryngoscope blade in. It's just getting around the corner, but also having a big chest in the way means even just where the handle is, we can't get around the corner. That's why ramping is so important. And when you actually look down to try and see where you're going to put your tube, if there's a lot of obesity, everything just collapses down, so your actual view that you have is a lot smaller. So smaller target now, and you also get caught on it with your intertracheal tube. But it still might be easy to put a supraglottic airway, which is a laryngeal mask in. Oops. Oops. Oh, I can't go back. There he is. So I reckon he would actually be easy because he can protrude his lower jaw. He's actually in the perfect sniffing position. So you can actually see there's actually like more of a straight line down to his larynx. So even though he's got a big thick neck and his BMI is enormous, I think the whole would be easy. So what I'm trying to say, it's not just about BMI and it's not just about big thick neck. It's very much an individual thing. So airway complications are increased in obesity. So there's a NAP4 study by the anaesthetic guys in the UK, and they're basically obese patients are twice as likely to develop serious airway problems during a general anaesthetic than non-obese. And there's higher failure rates of putting your laryngeal mask airway in or a Goodell, or even doing your emergency cricothyroidotomy if you can't get your intertracheal tube in or an LMA in. And of course, as you would expect, it's more adverse events with junior anaesthetic staff who aren't as experienced. So overall, obese patients are more labour intensive for us. Junior guys require more supervision from us. So again, giving us a heads up that you've got an obese patient means that we'll get the experienced consultant in with a registrar. You wouldn't let a registrar do a super morbidly obese patient by themselves because that is super high risk for everyone involved. And obesity also increases your risk of aspiration. So if you have an obese patient who doesn't have reflux, that's much more easy for us than if they do, because it just changes what kind of airway we have to put in. You can't put an LMA, a laryngeal mask airway in, if they've got high aspiration risk. You have to put a tube down no matter what the operation is. And in terms of sedation, if you're trying to sedate someone, if they're prone to reflux and you sedate them with something like midazolam and propofol, you're relaxing everything, you'll increase the risk of them refluxing. So it means sedation may no longer be an option for you. So an obese patient with reflux is a nightmare. So generally you'll have to go to a general anaesthetic instead. And if you go for a general anaesthetic, you'll have to do an intertracheal tube to protect the larynx from the reflux. And then, of course, you then have more time involved because you have to give them muscle relaxant if they're an adult, and then you have to wait a certain period of time before you can reverse the muscle relaxant and wake the patient up. So overall, it takes a lot more time than if you have someone without reflux that you can put under sedation, or you can give them a general anaesthetic with just a LMA in, because a laryngeal mask airway is considered safe to send to recovery, and the recovery nurses can take that out for you. So overall, a refluxing obese patient is going to take a lot more time than someone who's not. So just in case I know there's people that aren't doctors in the audience, so endotracheal tube, it actually goes all the way into your larynx versus a laryngeal mask airway, which sits above your larynx and doesn't protect your airway. And of course, if you've got an emergency case in a morbidly obese patient, so bowel obstruction, sepsis, trauma, they're really, really high risk for vomiting as they go off to sleep and aspirating. So you might be better off, in that case, doing an awake fibre optic intubation, because then you don't have all the problems with desaturating on induction plus potentially losing the airway with vomit. So of course, that will take a lot of time as well. So essentially, I think he would be a nightmare. I reckon he would be refluxing. I think he's hiding a small chin. He's got a beard, and he's probably got ischemic heart disease.